We were thinking, let's use it for whoever we think needs help with that work of breathing. And then we kind of had to narrow our focus towards bronchiolitis, which maybe possibly was the right answer, okay? So anyways, non-invasive support, we're gonna use it, we're gonna try to avoid like intubation, we're gonna try to overcome people's work of breathing. The interesting part about using these non-invasive setups is oxygen is over here and flow is over here, and that's what we've struggled with all these other devices that we've been using, right? There's a direct relationship between flow and oxygen and tidal volume and all that fun stuff. So non-invasive support, it's a simple interface, it's relatively easy to use. Did you guys sort of get a little anxious once this thing showed up on your floor and start to worry a little bit? Are you guys feeling better about it? Okay, throw questions at me as you want to, okay? It is relatively simple. It does provide some level of distending pressure. The key to this setup is that it is heated and humidified, and I can control that temperature, right? And separate that oxygen and the FiO2. We're gonna use it to reduce their work of breathing. We're gonna remove CO2. We're going to improve gas exchange. There's fewer infections, and that is directly related to the humidity that comes with it. We can reduce inflammation with that heat that's in there. And just to tell you, it is less stress on the patients and their families, right? A prime example that I had was we came out with this last year, and we were like, good job, everybody. We all sort of nailed it. The NICU was packed full of patients, and there were 2 sets of 24-week twins that were pending, and one of the attendings was like, I heard Ryan and those guys just passed high flow down on Baird 5. Did any of you guys catch this situation? So that NICU attending was like, yeah, that kid's got bronchiolitis. Kicked them out of the NICU to make space for these oncoming kids, right? That patient went down to your floor, but now suddenly you guys have a NICU patient, right? You're not used to those feeding protocols or those types of cares, right? But she said, yeah, we have bronchiolitis. Down we came to the floor, right? I started getting those phone calls on a Saturday or whatever it was, trying to argue against it. The pole came down with us, landed there, and then when everybody came in on Monday, it was super controversial that a NICU kid was now sitting down on your floor on high flow nasal cannula. Oh, and by the way, the attending said, yeah, we have bronchiolitis, but they never put it in a note. So that's not documented anywhere, right? Because bronchiolitis is one of those things that is a clinical diagnosis. Literally, you're like, yep, that kid has bronchiolitis, you know. So when we showed back up and we tried to, none of you had this patient? We tried to kick them off of your floor. You remember who it was? The mom was like, oh, hell no. No. I was upstairs in like an open fishbowl, and now you just gave me my own room and told me it's not that big of a deal. Well, if it's not that big of a deal, I'm staying, right? So that was quite the argument. So it just proved that point that it truly is less stress for the families and all those guys. When we use high flow nasal cannula, hopefully we're going to improve oxygenation, right? Because we have a blender that's on there. We're going to give a precise amount of oxygen. That flow is exceeding their inspiratory demand. That's super sweet. But secondary to that, we're going to remove CO2 by washing out that upper airway. So that's where that dead space will sort of sit in there, right? They would rebreathe CO2 if we were not washing it out with fresh oxygenated gas. What are the indications that we're looking for? You know, you're looking for that high O2 requirement. Have you guys read the high flow guidelines? I should have printed them out for you. I think I have them on here. But we're looking for grunting, flaring, head bobbing, retractions, not all of this stuff, just some combination of it combined with a low O2 or a high O2 requirement. If there's unexplained tachycardia, if we are guessing that there is CO2 retention, then we're going to head to this guy. This is what I was talking about. It's super important that we add heat and humidity to these patients when we're exceeding their inspiratory demand. Otherwise, like I was saying before, you are not optimizing their mucociliary transport system, right? Now, when you're pushing all that air into there with 100% oxygen from the wall, that is super cool. You're just sort of paralyzing that escalator system that's in there. And so it's not going to expel those secretions out of there. And at the same time, it's going to cool them down and sort of harden them. And now it's going to be hard for us to go in there and use that BBG and the little saline to suck all that stuff through, right? Without it, we do increase the risk of infection, and that is for the reasons that we're not allowing that mucociliary transport system to push out those pathogens that could cause infections, right? And will reduce their respiratory mechanics. Aside from that, there are like thermal regulation issues that we have with some of these patients. So it aids in thermal regulation. Down here you can see this is that mucociliary transport system pushing all this debris out of there, right? And then this guy over here is when it's paralyzed. You can see it's not pushing those secretions out, right? And then these guys, as they start cooling down, I think somewhere over here, for each gram of water that's removed out of the mucosa, you lose about 58 kcal right there. Take that however you want to.